Good morning. I'd like to introduce you to mixed reality, patient-specific mixed reality guidance for total hip replacement. These are disclosures and acknowledgments. So mixed reality, as you probably know, is the projection of digital content onto your view of the real world. And patient-specific mixed reality guidance is projecting three-dimensional information of that patient inside that patient with any associated instruments as well. So it gives you the effect of having X-ray vision where you can see through the drapes and the muscles to the relevant bones and tools that you otherwise would not be able to see, which makes it very powerful. So how does it work? Well, everything is based on three-dimensional modeling. So as with any of these other methods that are patient-specific, you get preoperative imaging, three-dimensional modeling. This shows cup planning, stem planning. Of course, we're planning relative to the spine as well, as was discussed a minute ago. So we just adjust cup position for the spine with all of the standing, supine, flexion, sitting information. And also plan leg length and offset, of course, and this is based on mathematics on a patient-specific basis, various landmarks on that patient to various landmarks on the implants. So then at the end of this planning process, you have 3D models of the patient, the pelvis, the femur, the cup, the stem, the cup impactor, screws, anything you want, and then it's a question of just what you want to project and when. Here's an example of a sequence of holograms that we would typically use clinically: the original pelvis, the pelvis ream to accept a socket, the cup impactor with the socket attached, the socket without the cup impactor, without the liner, screw trajectories and lengths, and the final construct on the pelvic side. So the question is, okay, you have all these 3D models. How do you anchor and track them and project them inside the patient? So these lenses, these head-mounted devices, many of them have cameras, and so these cameras are positioned very precisely, and you can use image recognition technology to use to replace the traditional cameras, the infrared stereoscopic cameras that you might see with regular traditional robotic or navigation systems. How do you register? That's how you track. How would you register? Well, you can register by putting a tracker on the patient like you would with any other navigation system, and then putting information in using a digitizer. The way that we typically do it, and this is the way that is being used in the United States routinely now, we have smart tools that dock to the patient on a predicted method, and if we know exactly how a tool is going to dock spatially on a particular patient, we can predict also where that image tracker is on top of that tool, and then we can do the math to project so that when the camera sees that image, it can project the information into the patient in the correct location. How is this done? Well, there was the HoloLens 1, which was from Microsoft, that was released in about 2016. We experimented with this early on, and it showed a lot of potential. It wasn't really quite at a surgical grade. It had a small field of view. It had limited memory, so we had to limit the size of the files that we were using. The tracking was good, but not excellent. But the nice thing about the HoloLens originally is that you could work out the software development, you could work out the workflow, you could start your testing algorithms, and then Microsoft published the software development information for the new HoloLens 2 before it was available. And so this allows you to write code for the device before the device exists, which is nice because then you have the code ready to be installed as soon as you get the actual hardware. So in terms of what you have to do, in surgery it's very simple. Regulatory-wise, not so much. There's a lot of things that you have to prove: electrical safety, image contrast, distortion, the effect of the surgeon's head motion on accuracy, the effect of the patient's motion on accuracy, the effect of combined motion, the effect of light intensity, light angle, anchoring angle between the head-mounted device and your image target. And then, of course, you have to do accuracy studies, which in this case was in cadavers and in calibration setups as well. This just shows we use screw placement as a surrogate for cup orientation, so we'd place lots of screws into bioskill specimens and then do CT measurements afterwards and measure the comparison between what we aimed for and what we got. And that's how the basic regulatory work was done. In terms of clinical applications, this shows displaying a reamer being used in surgery. There's typical routine cup placement where you project the pelvis, the tool, the cup impactor, and the cup. And we don't actually track the cup impactor. You just display to the surgeon where they should put the cup impactor, and they line it up and insert it. Another very nice thing, you know exactly where to rotate the cup so that the screw holes are in the right place, and then you know how long the screws are, and the screws are longer that way than they would be any other way, because you know that in advance. This just shows planning, and it's quite dramatic that a 10-degree rotation in the cup and location of the screw holes can double the lengths of the screws, so very minor changes in cup planning can lead to very major changes in fixation. It's nice also, I mean, it's not surprising, but you can see these osteophytes. Sometimes it's more fun to turn the OR lights way down and look at the mixed reality guidance rather than the reality itself. And you know, it's possible to display femoral-sided content. It's just a question of effort and what it is exactly that you want to see, but this can be done as well. Is it accurate? Last year we developed a method and validated it for measuring cup position based on biplane EOS back projection. Classically, you know, you could do a post-op CT. There's no clinical indication for that. You can do 2D, 3D matching, which we've done for about 15 years, but it's a lot of work, and it has to have a pre-op CT in order to do that. Biplace EOS back projection you can do on any patient, whether they had a CAT scan pre-op or not. You just measure the landmarks of the anterior pelvic plane on the biplane views. And then we have CAD models of the implants, and we place those CAD models in place so that when we make synthetic x-rays superimposed on the EOS, we replicate the exact same position. So this is what it looks like. Those are the two EOS images projected in this projection model, and we place an artificial cup in the right place that then recreates the exact x-rays that you're seeing on the EOS, and then you can figure out what the angle was from there. And so you can measure your accuracy quite easily that way, and this is a group of, I think, 35 surgeries, and you can see the accuracy there. Just about everything's within plus or minus 5 degrees in both planes, which is as accurate or more accurate than the robotic systems that are currently in place. So another fun thing, if you want to get intraoperative x-rays, you can display the coordinate systems in space, both functional and anatomic coordinate systems, both supine or in the lateral position. So if you want to get an x-ray, you can see exactly where the patient is, and you can line the patient up perfectly and line up the x-ray beam and get the correct x-ray right from the start, because you know what it's going to look like before you take it, and you never have to get an x-ray from the wrong angle. So in summary, mixed reality guidance, I think, is an evolution. Obviously, robotics is a little bit complicated, time-consuming, expensive, difficult, and not necessarily so much fun. This is very efficient, it's accurate, it's enjoyable, it's intuitive, and rather than taking work away from the surgeon and giving it to some other technology, what you're really doing is just taking the surgeon and enhancing that person's capabilities to be able to see and perform at a level that you can't otherwise do. So that's the current state. Thank you very much.